everyone. My name is Anju Aggarwal, and I'm a family physician in Sydney, Australia, and EC member. So, very warm welcome, everyone. Uh, tonight, I'm saying tonight because it's night here, but today we have got a excellent topic with the imaging in upper and lower limb extremity injuries by two of our very reputed speakers, Dr. Esha Agarwal and Dr. Gaurav Vashisht. So my job is to introduce Dr. Vinita Sharan. So I'll introduce Vinita, who is my, I would say, pen friend now. I still need to see. Um, Dr. Vinita Sharan is a senior radiologist consultant at Deep Take Medical Services. And Dr. Vinita is also adjunct faculty of Public Health Foundation of India. She's former associate professor, St. Beda College of Medicine, Philippines. Dr. Vinita is advisor of radiology CMEs of GAPIO and very instrumental in organizing radiology sessions for GAPIO. I think we have lost count, Vinita. Which session is your this? They say 11th, but I'm sure it's like 15th or 16th session.
Yes.
So really appreciate. Thank you very much for your contribution and welcome everyone. Thank you.
Yeah, thank you, Dr. Anju, for the kind introduction. And yeah, we have been partners in this webinar. And thank you for your continued support to our radiology webinars. Every time we reach out to you, you are ready to help us out. Thank you so much. And
Welcome.
greetings of the day, everyone, wherever you are. And firstly, happy Women's Day to all the multitasking female healthcare providers here in this group. Your hard work and dedication makes a lot of difference in the global healthcare. So thank you for your support to healthcare. And welcome everyone to the first Radiology International Lecture Series for 2025. The topic today is imaging in sports injuries. And we have two very good eminent speakers who will be enlightening us on role of imaging in sports injuries. But before that, just let me make this announcement that audience, if you have any questions, please post them in the chat box below. And let me now, without much ado, introduce our chairperson for the day, Professor Raju Vaishya, and we just heard from him how much of radiological work he has done, even as an orthopedic surgeon. So Professor Raju Vaishya, he is a senior orthopedic consultant and not joint replacement surgeon. He is adjunct professor, clinical tutor, and research advisor at Indraprastha Apollo Hospital, New Delhi, India. He has more than 38 years of experience as orthopedic surgeon and knee replacement surgeon. Dr. Vaishya has received several prestigious awards, including the B.C. Roy Award, in recognition of academic excellence. He has achieved world record documented in the Limca and India Book of Records for performing bilateral knee replacement surgery on the oldest patients, individuals and couples. Additionally, he has been featured in Asia Book of Records for his prolific research output during the COVID-19 pandemic. Dr. Vaishya authored over 800 publications in national and international orthopedic journals and book chapters. He is editor-in-chief of several esteemed journals and has position on editorial board of numerous reputable publications. He has achieved global recognition as one of the top 2% worldwide scientists worldwide for the fourth consecutive year. This prestigious acknowledgement is a testament to his exceptional skills and contribution to the field. I now invite Professor Raju Vaishya to introduce the topic and the speakers. Sorry. Sir, you're muted.
Thank you, Dr. Vinita, and good evening to everyone. I am Dr. Raju Vaishya. I work at Indraprastha Apollo Hospital for last 28 years. I'm also the editor of our in-house journal, that is Apollo Medicine, which is now an international journal, and we take multi-specialty publications, including radiology and orthopedics and other branches. So today, in this webinar on imaging and in sports injuries of the lower and upper extremities, we have two distinguished speakers. So I will introduce the first speaker, Dr. Esha Agarwal, who is a consultant radiologist in Manipal Hospitals, Pune. And she completed her MSK fellowship and DNB radio diagnosis from the same institute, that is Dinanath Mangeshkar Hospital and Research Center in Pune, which is a very reputable institution. She has presented several papers and posters at national and international conferences and has also published original research articles in various journals. She is interestingly the creator of radiology content on Instagram, which are humorous and related to radiology to explain public and the newcomers about the radiology concept and its related problems. In today's webinar, we are going to discuss sports injuries, which are common occurrence amongst athletes and physically active individuals, often affecting lower and upper extremities, apart from sometimes back injuries. These injuries can range from acute trauma, such as fractures, ligament tears, cartilage injuries, chronic overuse conditions like tendinopathies, tendon ruptures, and stress fractures. In these conditions, accurate diagnosis and prompt diagnosis is critical for effective treatment and rehabilitation. And here, the medical imaging or radiological imaging plays a pivotal role in this process. Without radiology, orthopedic surgeon is nothing. This webinar will explore the various imaging modalities that are commonly used in diagnosing sports injuries of the lower and upper extremities, their applications, their advantages, and limitations. Mainly, we'll be focusing on plain radiography, that is X-ray, ultrasound imaging, magnetic resonance imaging, computed tomography or CT scan, nuclear medicine, or bone scan. Nowadays, another combination of medical imaging, that is PET CT and PET MRI, has also come, and we have been actively actually doing a lot of research with Dr. Jaina in our hospital at Indraprastha Apollo Hospital. So without much ado, I would invite the first speaker, Dr. Esha, to present her talk in the upper extremities imaging in sports injuries. Over to you.
Thank you so much for the introduction, sir. So, good evening, good morning, and good afternoon, everyone. I will be talking about imaging of the sports injuries in the upper extremity. This is just a flow of the talk that we are going to see. A short introduction, followed by a classification of sports injuries, followed by some common injuries that we see in the shoulder and the AC joint, the elbow joint, wrist, as well as the hand and fingers. So sports-related upper extremity injuries are very common, especially with overhead throwing sports. Imaging plays a crucial role in diagnosing and assessing them to guide a targeted approach to rehabilitation and training regimens to reduce the risk of long-term damage as well as enhance return to play decisions. The various imaging modalities used are X-rays and CT scans for fractures as well as MRI and ultrasound for the soft tissue details. So any type of sports injury can be classified based on the duration or cause into acute injuries as well as chronic or overuse injuries. Acute injuries may be the direct impact injuries or indirect injuries, and based on the tissue type into soft tissue or hard tissue injuries. Shoulder injuries account for approximately 8 to 13% of all the sports injuries. Let us see some of the common mechanisms that are involved. It may be overhead or repetitive arm movements such as in baseball, cricket, tennis, swimming, etc. Due to direct contact and collision sports such as football and rugby. Forceful arm movements such as in boxing and martial arts, as well as in activities that involve climbing and reach-based movements. So first we'll see shoulder dislocation, which are a common sports injury, especially in contact sports and activities that involve overhead motions. Most common among them is the anterior shoulder dislocation, which accounts for approximately 95% of the cases. So in this frontal radiograph, you can see that the humeral head is located anteriorly relative to the glenoid. The associated injuries that you see with the anterior shoulder dislocation is a posterolateral impaction fracture of the humeral head known as the Hill-Sachs lesion, as it impacts against the anterior glenoid. Are you able to see the cursor?
Yes, yes.
Okay. As well as a Bankard's lesion, when the humeral head impacts against the anterior glenoid, there might be a tear of the anteroinferior labrum, which is known as the Bankard's lesion. If it is associated with an underlying glenoid fracture, it is known as a bony Bankard's lesion. Posterior shoulder dislocations are relatively less common. So this is a scapular Y view, which is showing a posteriorly dislocated humeral head. So we have something called as a light bulb sign on the AP view, where the humeral head appears rounded and symmetric because of internal rotation. So you have the counterpart of Hill-Sachs lesion, that is the reverse Hill-Sachs lesion in the posterior dislocation, when the humeral head impacts against the posterior glenoid rim. Next, we have the AC joint injuries, which may occur either due to a direct blow or they can occur due to an indirect injury when the force is transmitted when the player falls on an outstretched arm. So there are 6 types according to the Rockwood classification based upon the condition of the acromioclavicular and the coracoclavicular ligaments. So in this coronal image, you can see that there is a rupture of the acromioclavicular ligaments as well as surrounding soft tissue edema. The sagittal image shows that there is rupture of the coracoclavicular ligament. So this is a type 3 type of AC injury. This is just a reference to show an intact coracoclavicular ligament. Next, we can also have rotator cuff injuries, which is common in either acute trauma or overhead activities. Tendinopathy is more commonly seen in the younger population, whereas ruptures are more commonly seen in players over the age of 40 years. So as you all know, rotator cuff tears can either be partial thickness or full thickness. And again, partial thickness tears can either be articular-sided as seen in this image, bursal-sided, which are often related to impingement, and intra-substance tears. This image shows a full thickness tear of the supraspinatus tendon where there's a complete defect extending from the articular to the bursal surface. Also important to mention in the report is the degree of tendon retraction as well as the condition of the muscle belly where muscle atrophy might be seen in chronic tears. Next, we go on to labral tears. Labrum deepens the socket and enhances the joint's stability. The various types of tears that can be seen in sports-related injuries are the Bankard's lesion, which we already saw in the anterior shoulder dislocation. Other tears that may be involved are the slap lesion and posterior labral tears. So, apart from the soft tissue and bony Bankards that we saw, we can have other variants. Perthes lesion, where the periosteum is intact. Glad lesion, where there is disruption of the articular cartilage, and ALPSA, or as the name suggests, anterior labroligamentous periosteal sleeve avulsion, where there is avulsion of the periosteal sleeve. Normal variants can also be seen, such as the sublabral recess and the sublabral foramen. However, these are more commonly seen in the anterosuperior quadrant, whereas all these injuries are more commonly seen in the anteroinferior quadrant. Slap lesions are nothing but superior labral tears from the anterior to the posterior side. A peel back mechanism has been described, which explains the slap injuries in athletes. So this most commonly occurs in overhead throwing activities where the humeral head is in the aber position, that is abduction and the external rotation position. So as the humeral head rotates, this dark blue one is a biceps tendon. It causes a twisting of the biceps tendon, which leads to transmission of forces to the biceps anchor as well as the labrum, leading to a tear. So there's an extensive classification involving the slap tears. We won't go into the details, but it is important to mention the extent of the tear, the labral tear, the quadrant and the clock positions involved, as well as the condition of the biceps anchor. Posterior labral tears can be seen with posterior shoulder instability, such as in contact sports or weightlifting. So in this image, you can see that there is a fluid signal between the posterior labrum and the glenoid, suggestive of a posterior labral tear. So there's a specific entity called as the batter's shoulder. This image shows the follow-through phase of a batter, like when the batter has just hit the ball or missed the ball. The shoulder is in a flexed, adducted and internally rotated position. So what happens in this position is that the humeral head exerts a posterior force on the glenoid, leading to a posterior labral tear. So we saw shoulder dislocations, labral tears and rotator cuff tears. Next, we'll go on to the impingement syndromes. The two common types, that are the subacromial or the external impingement as well as the internal impingement. So subacromial or the external impingement occurs due to compression of the supraspinatus between the humeral head and the overlying acromion or the coracoclavicular ligament. It is most often seen in athletes that perform throwing mechanisms such as volleyball, handball, tennis, etc. Imaging findings on radiograph might include a reduced acromiohumeral interval, which is usually less than 7 mm or 6 mm. Type 3 acromion or acromial spurs might be seen. A component of AC osteoarthrosis may be seen, as well as tendinopathy involving the supraspinatus and the SASD bursitis. Next, we have the posterior-superior or the internal impingement seen due to external rotation and abduction forces. So what happens here is the undersurface of the rotator cuff tendons, mostly the infraspinatus, impinge against the posterior-superior glenoid. So this results in articular surface tears of the infraspinatus and sometimes also the posterior supraspinatus. And as we saw earlier, because of the peel back mechanism involved in external rotation, there might also be slap tears involved, as well as some associated humeral head cysts. Now, let us look at these three images. Image A is that of a normal person, which is showing the normal degree of internal rotation as well as external rotation. This is the total arc of motion. In overhead throwers, what happens is there are some adaptive mechanisms which increases their external rotation. And in compensation, there is some loss of internal rotation that is seen. However, the total arc of motion is maintained. However, in some players, there is an increase in the external rotation, but the internal rotation loss exceeds that of the external rotation gain. So as you can see here, the external rotation has increased, but the decrease in internal rotation is much more. So this leads to a deficit in the total arc of motion, and this is known as the glenohumeral internal rotation deficit, GIRD. So as we saw earlier, since the mechanism is again external rotation, we will have strain on the posterior capsular structures, leading to posterior capsular thickening. Internal impingement lesions may be seen, as we saw earlier, partial thickness tears of the infraspinatus labral tears, as well as the adaptive mechanism, that is humeral retroversion, may be seen. So this image shows a curvilinear ossification along the posterior inferior glenoid rim. The mechanism is traction by the posterior band of IGHL in overhead throwing motions. Again, there's a strain on the posterior structures. This is known as the Bennett's lesion. So physis is a weak point in skeletally immature players. So overuse injury leads to proximal humeral epiphysiolysis, also known as the little leaguer shoulder, commonly involved in young baseball pitchers and other overhead throwing athletes. As seen in this X-ray, we can see that there is some amount of physial widening, mostly on the lateral side. In extreme cases, sclerosis and fragmentation may occur. MRI will show an edema in this region. Now let us go on to the next joint, elbow. So as in the shoulder, the main stressor was the external rotation. In elbow, we have valgus stresses. Valgus stresses are common in a lot of sports. So we have something called as the valgus extension overload syndrome, also known as the pitcher's elbow. So as you can see in this diagram, what happens is there are increased tensile forces on the medial side, compressive forces laterally, and shear forces posteromedially. So this leads to injuries on the medial side of the structures, that is UCL injuries. On the lateral side, you have the radiocapitellar joint, so you can have lesions such as the OCD, osteochondral lesions. And posteromedially, you might have some osteophytes, a specific osteophyte called as the VEO osteophyte. We'll just see these one by one. So the ulnar collateral ligament is the primary restraint to the valgus stresses. So whenever there's a valgus stress, this is a very common injury that is seen. UCL may be thickened, ossified, partially or completely torn. So in this image, we can see something called as a T sign. There's a partial tear of the UCL from the sublime tubercle. Next, we saw that valgus stress can lead to compressive forces on the lateral side. So this can give rise to osteochondritis dissecans, the repeated bony injuries, most commonly seen in adolescent athletes. Next, we have the medial epicondylitis or the golfer's elbow. It involves the medial surface, the common flexor tendon origin, and is commonly seen in repetitive wrist flexion, such as in golf or baseball players. As we saw in the little leaguer shoulder, the physis is the weak point. So whereas in adult, you will get a UCL injury, in children, there is the impact of the trauma is mainly seen on the physis. So there can be widening or irregularity of the physis, and in severe cases, fragmentation and avulsion may occur. This is known as the little leaguer's elbow. This is just a normal site to show the regular physis that is seen here. Lateral epicondylitis or the tennis elbow involves the overuse of the extensor tendons, most commonly the extensor carpi radialis brevis, common in tennis, golf, or repetitive gripping activities. It is much more common than the medial epicondylitis. So in fact, even in golfers, tennis elbow is more common. Now, wrist and hand are some of the most active joints involved in sports, but they are the least protected. So this leads to a lot of injuries in this region. The mechanisms include fall on an outstretched hand, repetitive loading as seen in gymnastics, high velocity impact such as in contact sports, and twisting or torsional stresses. We will just see a few of the common fractures. So scaphoid fractures are the most common, resulting from fall on an outstretched hand. Specific radiographic scaphoid views might be done, and it is important to detect and diagnose this injury early. So MRI is highly sensitive to detect bone marrow edema as well as the fracture lines. Next, we have the hamate hook fractures can occur in racket sports, either due to direct impact or from a forceful grip. This is a specialized carpal tunnel view, and you can see the fractured hook of hamate here. And obviously, CT will provide an excellent resolution to visualize the fractures. Then we also have the scapholunate ligament tears, which can lead to carpal instability. occur due to repeated trauma or even high energy trauma. Radiographs will demonstrate a widened scapholunate gap, which would be more than 3 mm, which you call as the Terra-Thomas sign or the Madonna sign. And MRI will show tear of these ligaments as well as the fluid signal between. TEFCC tears are also relatively common, especially in tennis, gymnastics, and racket sports. MRI is the modality of choice to evaluate both the traumatic and degenerative lesions. So this also forms the basis of the Palmer classification, where you classify tears into either traumatic or degenerative. So in this image, you can see that there is some fluid and tenosynovitis of the first extensor compartment tendons, that is the abductor pollicis longus and the extensor pollicis brevis. This is known as de Quervain's tenosynovitis, commonly seen in golf, racket sports as well as rowing, which involve repetitive gripping and thumb motions. Another specific entity which is concerned with skeletally immature athletes is the gymnast's wrist. So it occurs due to high impact weight-bearing maneuvers, leading to excessive axial load as well as hyperextension stresses on the wrist joint. So there is a widened irregular distal radial physis, and in later stages, sclerotic changes may also be seen. MRI will demonstrate a bone marrow edema in this location. Now, a few injuries involving the hand and fingers. Sometimes there can be a forceful flexion of an extended finger, such as when the ball strikes the tip of the finger. This is known as mallet finger because the patient presents with the flexion deformity and an inability to extend. On radiographs, you will see a small bony avulsion at the dorsal base of the distal phalanx, and an MRI can be used to demonstrate a tear in the extensor tendon. Its counterpart is the jersey finger, where there is forced hyperextension of a flexed finger, for example, when grabbing or tackling in football or rugby. So the patient presents with an inability to flex the distal phalanx. Radiographs will show an avulsed bony fragment on the volar aspect of the phalanx, and MRI will be helpful to assess the FDP tendon. Next, we have the boxer's knuckle, which is different from a boxer's fracture. Boxer's fracture is a fracture of the fifth metacarpal, whereas a boxer's knuckle refers to an injury of the sagittal band. Now, what are these sagittal bands? These are nothing but structures that keep the extensor tendon in position at the metacarpal head. An injury to these bands can occur during repetitive blunt trauma, such as in boxing or martial arts. So the ulnar side band and the radial side band, either of them can be torn. Radial side tears are more common, which will ultimately lead to subluxation of the tendon. So MRI and ultrasound will again reveal the discontinuity, that is loss of visualization of the sagittal band, as well as mild subluxation of the tendon. Next, we have the skier's thumb or the gamekeeper's thumb. It occurs when there is forceful abduction of the thumb. Likely when the patient is gripping a skiing pole and there is a history of fall. So this will lead to a rupture of the ulnar collateral ligament. It can be assessed by ultrasound. Ultrasound can also provide dynamic assessment or also by MRI. Radiographs can reveal an avulsed bony fragment at the UCL attachment. And it is important to identify a Stener's lesion where the abductor aponeurosis is seen deep to the UCL, which will prevent its healing, thus necessitating surgery. So you can see that there's a rupture of the UCL in this case. However, no Stener's lesion was seen. So this is the last injury in the upper extremity for today, the flexor pulley injuries. So we have 5 annular pulleys, the odd numbers 1, 3, and 5 at the joints, and the even numbers 2 and 4 at the phalanges. So forceful gripping and climbing activities can lead to tear of these pulleys, most commonly the A2 and the A3 pulley. So these pulleys are responsible for keeping the flexor tendon in opposition to the bone surface. So whenever there is a tear of these pulleys, there is bowstringing of the tendon away from the bone, which can be diagnosed on ultrasound as well as MRI. So in summary, we saw the common injuries in the shoulders, that is the dislocations, the cuff tears, labral tears, AC joint injuries. Elbow, we saw the UCL tears, the medial and lateral epicondylitis, OCD. Wrist and hand, the various fractures, TFCC and scapholunate ligament tears, as well as some specific sports-specific injury patterns such as the GIRD, which occurs because of external rotation, the valgus extension overload syndrome, and as well as specific entities in pediatric athletes such as the little leaguer shoulder, little leaguer's elbow, gymnast wrists. The takeaway point is early diagnosis of all these injuries is very important as it will help to prevent chronic dysfunction. So these are my references. And also Vinita ma'am had strictly said to keep the talk within 20 minutes, otherwise it's an extensive topic and we'll just go on and on. This player probably had a jersey finger after this. So I hope I finish within 20 minutes.
Thank you, Dr. Esha, for fantastic disposition of all the major injuries of upper limb. You covered in 20 minutes very well. Thank you. There are a couple of questions. One from Dr. Shailendra about if you have a Hill-Sachs lesion in a case of recurrent dislocation, do you always need CT scan and MRI both for assessing the depth of the lesion or the extent of the lesion?
As of now, CT obviously provides better measurements and it has better accuracy. But even with the MRI, we have something called as the zero TE sequences, which gives bony detail as well as the CT. So I would say for better accuracy, as of now, CT is important because it will help you give the glenoid bone loss and all the measurements accurately. However, MRI is not far behind.
And another question from the same person, that what are the most important points that you look out for rotator cuff injuries in MRI? Especially for orthopedic surgeons, what should they be looking for most importantly?
So in any rotator cuff tear report, firstly, you will need to mention whether it is a full thickness tear or a partial thickness tear.
Yeah.
Also, the extent of the tendon involved, that is the AP extent, whether it is a complete tear or only some part of the tendon is involved. Next, you would need to give the tendon retraction, whether it is like stage 1, 2, or 3. And also followed by how is the muscle condition. Because if the muscle is very atrophic, I don't think repairing would lead to that much improvement in the patient's condition.
And which are the best views to look out for or to assess rotator cuff injuries in MRI?
For supraspinatus, start by looking at the coronal image. For the infraspinatus, start by looking at the axial images. And always correlate these with the sagittal images.
Fantastic. And can Hill-Sachs lesion be isolated without associated Pankart lesion? Or let me put it the other way, is Hill-Sachs lesion a cardinal sign to indicate if there is recurrent dislocation happening in a patient, even if you have an intact looking labrum?
It usually does indicate that there are recurrent dislocations happening because the mechanism of a Hill-Sachs lesion is that the humeral head has moved forward and impacted against the anterior glenoid. So this invariably will lead to some injury to the anterior labrum, though that is not always the case. Sometimes you might find an intact labrum, but that is very rare. So in case you feel that the labrum is intact, still go back and have a look. You might find a tear.
Very good. Another question on posterior shoulder dislocation. Suppose you see a light bulb sign on the X-ray. Will you be satisfied in diagnosing it, or would you go further and do CT or MRI for this patient?
As opposed to anterior dislocations, where there is significant dislocation of the humeral head and which is easily picked up on radiographs, posterior dislocations are very subtle. And there might be some artifacts related to the light bulb sign, like the patient is in some internal rotation. The sign that we saw is because the shoulder is internally rotated. So a further evaluation would be advisable.
Fantastic. You mentioned about, the Hill-Sachs lesion. What about measuring the glenoid bone defect, especially in chronic lesions, or if there is a bony Bankart lesion? So do you rely on CT scan or MRI, and how do you quantify the defect?
As I said, the best accurate one as of now would be CT, though MRI is catching up. And there are various methods to measure the glenoid bone loss. I think that will be an entire separate lecture altogether. But then there's a best fit circle method that you can use, or you can compare it with the normal shoulder if you know that the other shoulder is normal.
Great. I am very happy to share and introduce a very eminent MSK radiologist from United Kingdom, that is Professor Rajesh Borchu, who is into MSK radiology at Birmingham, UK. And he has done a lot of work on various modalities like MRI, ultrasound, etc., for shoulder injuries and other injuries. So may I invite him to give a brief overview of the latest happening in this field?
Our next speaker is Dr. Gaurav Vashisht, or you want some?
Now, I wanted an opinion of Dr. Rajesh Borchu. Is he there? Okay. If he is not there, then we leave it. And then let us go to the second talk of the day by Dr. Gaurav Vashisht on lower limb injuries imaging. Dr. Gaurav Vashisht is a consultant radiologist at Arthocenter at Jyoti Hospital, Gurugram. He has done his fellowship in MSK radiology from InnoVision Imaging in Mumbai. He was also a visiting fellow in pediatric rheumatology at Germany. His interests are in imaging guided interventions, and he has contributed several chapters in radiology books and is an active teacher in radiology teaching programs. So I invite Dr. Gaurav Vashisht to start his talk. Thank you.
Thank you so much, sir, for the introduction. A very good evening to all of you from India. As it's a 20-minute talk, discussing lower limb injuries is a little difficult, but I would like to cover the entire spectrum of what we see in our common OPD practices in the MSK clinic. So let's go what the imaging holds us holds a place in sports injury. So the first and foremost thing is that imaging, apart from clinical examination, helps us to identify fractures, dislocations, soft tissue injuries, ligament and tendinous tears, and other structural abnormalities in the background. And for practicing physicians, it's important that the choice of imaging modality depends on the clinical presentation, the type of injury suspected, and the specific area of lower extremity which is being evaluated. Because every imaging modality has its own importance, and it gives us a better way to take the treatment ahead. Also, imaging helps us in guided interventions for pain management and promoting the healing process. So the common injuries which we encounter in the lower extremities are the fractures, specifically the femur, tibia, ankle, and the bones around hip joint. The fractures can be avulsion fractures, or they can be just stress fractures or stress-related injuries. In the lower extremity, all the joints are being stabilized by various ligamentous structures, which helps to maintain the alignment and helps in easy motion while playing the various sports. So like ligament like ACL, PCL, the anterior and the posterior cruciate ligaments, the medial collateral and the lateral collateral ligaments, they stabilize the uh, knee joint, while various ligaments like ATFL, AITFL, or the calcaneofibular ligaments, they help to stabilize the ankle. So similarly, meniscal injuries, the meniscus being the fibrocartilaginous structures, they help as a maintaining the cushioning effect in the knee joint and is very common in the sports arena. Next is the tendinous injuries, which again is severely involved in various sporting activities. Muscle injuries and dislocations are the next areas, which is of great concern to the sports player, because it is important as radiologists for to actually assess the right grade of injury so that the comeback in the sport can be assessed and the patient can be given appropriate care. So this is the kind of pain which the sports person bears when he gets injury in the field. So the lower limb injuries are primarily divided in the lower limb being the hip and the spine area, which is affected, then the groin and thigh, knee and calf region, then we have the leg, foot, and ankle. So I will be not going into all the details of pathologies pertaining to the joint involvement, but rather move ahead with the type of injury which we see. So various imaging injury mechanisms are there. Like the most common injuries which we have in the lower limb happens while the person is running in the field, and because of sudden stop when the body is running, the inertia, it's in high velocity, but whenever there's a sudden stop out there, the whole body just turns around, there is this twisting, and the shear forces go against the ligament, and because of the twisting and the rotational forces, there is ligament pull, there is injury, and hence it could be a low-grade injury, an intermediate-grade injury, or a high-grade injury, depending on how the shear force and the rotational forces have acted upon. So it's important to identify the cause of injury and the injury patterns which we see on imaging. So the first and the foremost, the most common things are which we see in the practice is like in the traumatic setting is a fracture. So the fractures are nothing but break discontinuity in the cortical outline. And as we all know that fractures, the body has its own healing mechanism. The fracture will heal on its own when it is allowed to rest. But there are certain types when the fractures are displaced. It's important for us as radiologists to help our fellow physicians and orthopedic colleagues to know what kind of fracture is it. Is it a displaced fracture or not? Is it a fragmented fracture or not? Is there an apex angulation, either posterior angulation or anterior angulation? And other areas, is the articular surface involved or not? Or is there an articular body or an intraosseous, in the intra-articular loose body inside? So it's very important for us to give an information about if there is any dislocations, and if yes, we have any doubt about the intra-articular fragments, the CT scan would be really helpful before a person is taken into the OR. So these are the various images which describe various fractures. Here we can see that there is fracture along the lateral tibial plateau, and there is mild step off here along the posterior aspect. The fracture fragments do look little fragmented here. However, the tibial spine looks absolutely fine, while the medial tibial articular surface is very smooth and intact. On the other lateral radiograph of the knee joint, we see that there is large effusion inside the suprapatellar recess of the knee joint, and there's a displaced fracture of the patella. In this frontal radiograph of the femur and thigh, we can see that there's a displaced fracture, transversely oriented fracture in the proximal shaft of femur, and hence there is displacement by over half shaft width. So these type of fractures are very important for us to inform the clinician ASAP. Why? Because these can be the long bone fractures can lead to fat embolism, and specifically in a sporting setting, it can be very dangerous for the patient. In cases we can have stress over these bones, there could be some cortical thickening and stress fractures which might arise in the long bones. So this was a fibular stress fracture. And here we can see an oblique fracture in the fifth metatarsal distal shaft, and there was a joining soft tissue swelling. So X-rays are the beautiful modalities. The radiographs are the first imaging modalities which we should order for a patient who has come with trauma. And once we are set in that what kind of injury it is, we can decide on that we need further investigation or not. Other set of fractures are known as stress fractures, which means that there is more weight on weak bones, or there is the bones are strong, but the load has been tremendous. So in such cases, X-rays are as I said, for any pain, X-rays will be the first modality of choice. But X-rays have to be read in clinical correlation. So that is why it's already very important for us to know what's the clinical scenario behind. So this was a frontal radiograph of a skeletally immature patient. And here, essentially, this X-ray was read as normal. But then what we saw was that there was a thin lucent line in the neck region, which was later appreciated on a frog leg lateral radiograph, which we ordered later on to confirm it. And so usually for stress fractures, the X-rays could be within normal limits. They could be subtle sclerosis there, or they could be a linear lucency in the radiograph at the site of pain. Usually these stress fractures are non-displaced, and MRI is the investigation of choice to rule out stress fractures because they present with a bone marrow edema pattern, which could be best seen on STIR, which are the proton density fat saturated images. So it's very, very important for us to order the right imaging modality. So whenever in doubt, you should not hesitate to get a higher investigation, but then yes, always look these investigations in the background of clinical setting. So for this patient, the MRI was done, and we could see that there was bone marrow edema in the neck region and intertrochanteric area, and we could see a thin hypointense fracture line in the femoral neck region, which was a stress fracture. Certain times, because of overloading of the bones, when the bones are weak, the trabecular disruption happens. And specifically in young sport people, when they tend to ignore their knee injuries, there might be development of early osteoarthrosis or arthritic changes, along with low vitamin D and other metabolic causes could lead to trabecular disruption, which could lead to subchondral insufficiency fracture. So subchondral insufficiency fractures are not just limited to the sporting people population, but to other age groups as well, where there are metabolic changes. So in this MRI image, which is a sagittal proton density weighted fat suppressed image, we could see that the bone marrow fat is completely suppressed here, and hence the bone is looking black. But however, we can see a thin hypointense, a dark linear fracture line in the medial tibial plateau and extensive bone marrow edema in that region, which is centered out here. Along with that, we could see some degenerative changes in the posterior horn of medial meniscus and some cartilage wear happening here. There is some sort of some Baker's cyst, which we could see, but that's essentially non-ruptured. Another example to show subchondral insufficiency fractures are extensive bone marrow edema along the medial and lateral tibial plateaus, and we could see thin subchondral hypointense fracture lines on these images. So whenever you have extensive bone marrow edema and you have no other history of any infection or something, just try and look how this is happening. Is there any history of trauma or not? And in cases where you have trauma, then you have to look for what kind of trauma it was, and hence you can reach to the diagnosis. And these patients can be managed pretty conservatively with mild non-weight bearing and metabolic correction. Similarly, in the hip region, as there is axial loading, because hip, knee, and ankle, it forms one axis, and all the weight from the spine is transmitted to the ankle through these joints. So whenever you have a long-standing dull aching pain which is happening on one side or both sides of the hip joint. X-rays are the first investigations of choice, which could be normal, may show sclerosis or linear lucency, but we need to be very, very sure of what we are looking at and we are not missing on something. So when we look on the MRI, we can see as compared to the right side, the left femoral head, neck, and intertrochanteric region shows extensive bone marrow edema, and we see a thin subchondral hypointense fracture line because of overloading on the weak bone. So this is a subchondral insufficiency fracture, and we should be very, very careful to rule out an underlying avascular necrosis whenever there's a patient with long-standing persistent hip pain. So avascular necrosis will present with serpiginous geographical areas in the femoral heads, and they will be associated bone marrow edema. So it's important for us to differentiate between the two because the treatment is altogether different. Another area which we usually see in the runners, specifically in the era of marathon and extensive daily running, so is the medial tibial stress syndrome. So because of the medial tibial area getting repetitively getting friction against the soft tissues, there is development of cortical thinning along the anteromedial cortex and associated subperiosteal soft tissue edema. So X-rays in such cases may demonstrate cortical thickening, but MRI will help to identify bone marrow edema pattern along the anteromedial tibia, and STIR or PD fat saturated images would be really helpful to identify what's happening. So these are also called shin splints. Another area in the runners is the stress fractures in the foot region. So X-rays again is the first investigation of choice because the patients present with pain and swelling along the dorsum of the foot. But essentially the patient doesn't remember that he has had a significant injury in the past. So in such cases, X-ray may be within normal limits. It may show subtle sclerosis or fluffy periosteal reaction. But ultrasound is again a very, very beautiful investigation to look for patients who have dorsal foot swelling. And here we can identify that there is a discrete discontinuity or there is some irregular cortical proliferation in the metatarsal shaft. So this is a linear metatarsal cortex, which we are seeing here. This is the third metatarsal. And on the second metatarsal, we see that there is a small callus formation, some periosteal reaction, which is happening, and there is subperiosteal edema. So this was a case of stress fracture in a runner, and which was confirmed on the X-ray as thin peripheral, some fluffy periosteal reaction. To our surprise, we could also see there was a thin fracture in the fifth metatarsal proximal shaft as well, but the patient wasn't symptomatic here. Another set of injuries are the avulsion injuries, which happen at the site of epiphyseal attachments. And in the hip region, it may be present at the anterior superior iliac spine, the iliac crest, the anterior inferior iliac spine, the greater trochanter, the lesser trochanter, the ischial tuberosity, and the symphysis pubis. So these are the areas which give attachment to abdominal walls and various muscles, and specifically in the adolescent and pediatric age group, because these are soft areas, just by some traction, there can be development of avulsion injuries. So this is a front. So X-rays are again the first imaging modality in any orthopedic sports injury practice, and reading X-rays is actually fun. So you just cannot miss reading the radiographs and not just jump on the MRI. So the basics have to be kept basics, and we will find a lot of things on the radiographs as well. So this is the frontal radiograph of PBH region, and we could see that there was a small avulsion fracture here at the ASIS, or the anterior superior iliac spine attachment, which holds the sartorius muscle in place. And MRI follows to confirm the status of soft tissues if it's really displaced, just to look for how much retracted it is. Similarly, from AIIS, we can see the anterior inferior iliac spine shows a thin sliver of bone, which represents an avulsion fracture of the rectus femoris muscle. So the rectus femoris has two heads. One is the direct and the indirect head. So the direct head comes from the anterior inferior iliac spine, while the indirect head comes from the acetabulum. So this represents a fracture of the direct head with a small osseous flake. And this could be seen very easily and very beautifully on the frontal radiograph. So something which I wanted to mention is that in a non-traumatic setting, this could be a case of calcific tendinitis. But in a traumatic setting where the patient, when a patient is a sports player and is into active running and repetitive sport events, So this could be concerning for an avulsion fracture. Similarly, if a patient here who presented with the buttock pain on the left side for many days, and X-ray essentially was read as normal, but we could see that there was some osseous irregularity here in the left ischial tuberosity, which gives attachment to the hamstrings. So this was an area of an avulsion fracture of the hamstring injury, and MRI follows to confirm the status of the tendon and any neurovascular structure injury. So on a frog leg lateral radiograph, we can see that how this beautiful smooth contour of the cortex is disturbed here and has become little irregular and fuzzy. So this represents avulsion fracture of the hamstring tendon. So sometimes there could be avulsion injury of the soft tissue without bony fracture. So in such cases, X-rays will be normal, but the patient would have tremendous pain, and hence MRI would be a beautiful investigation to look for bone marrow edema pattern in the trochanteric region. And this is the site for attachment of the gluteus medius and minimus tendons. So hence there was some avulsion, the soft tissue avulsion here, and possibly a cortical break must have happened. That is why there is bone marrow edema in the bone, while the left side is asymptomatic. MSK ultrasounds can also help in dynamic assessment of these areas and can pick up small avulsion injuries. Similarly, we can see that there was avulsion injury without any bony fracture. It was like a gluteus medius insertional tear, and the bony part is intact. So MRI is the best imaging modality to look for bone marrow edema and soft tissue status together. However, as I said, dynamic ultrasound can be also be tried in settings where you have no good facilities for MRI. Other set of injuries which we come across are the groin injuries. And again, as I said, X-rays are the first line imaging modality which rules out fracture and femoral head pathology and any bony destructive lesion. But the best investigations to look for groin injuries are the MSK ultrasound and MRI. So these are the ultrasound images where we could see that this is the adductor longus muscle and this is the pubic bone. And if you see on the long axis, this is the tendon which is coming. And when it is attaching to the pubic bone, there is an undersurface partial tear along with irregularity of the bone. And we can see that this is the area of partial tear. So these irregularity can be well seen on the X-ray, but the soft tissue status is evaluated on an ultrasound. And along with that, we can also try giving regenerative therapies to the patient in cases of partial tear. And here we injected the PRP in such patients. And as I'm injecting, I can see that the fluid is extending along the site of tear and the area of tear has been exposed. So we are sure of that where we are injecting because ultrasound gives us a targeted approach. Next, in the pattern of adductor longus injuries or groin injuries, the bone marrow edema pattern along the pubic symphysis. And MRI helps to assess the tendon integrity, the rectus abdominis, adductor aponeurotic status, and the bony changes. So these were stress edema pattern in cases of athletes along the pubic symphysis. And similarly, here we can see that there's an undersurface tear of the adductor longus tendon at the pubic attachment, and associated we can see that there's a high-grade undersurface tear on the sagittal image, and the pubic symphysis and adductor tendons can be beautifully appreciated. Also, we can see there's a small tear on the undersurface on the opposite side, which are seen on MRI. In this patient, as we could see in the previous image, that there was a lot of edema here in the muscle, which is a feathery pattern edema. And on a dedicated axial image, we could make out that this was a low-grade injury for an extent of 9.6 centimeter and some small fluid collection. So grade 1 to 2 injury was seen in the vastus lateralis muscle belly, and the patient had to stop playing for some time till gets okay. Next section is the hamstring injury, which is again very, very common part. X-rays, first line imaging modality, as we discussed in the past. So MRI and MSK ultrasounds are beautiful ways to identify what kind of injury it is. And hence, because the return to play portion is the most important part, which comes from the radiologist as to how the muscle is healing well. So unless we give proper classifications and proper information to the sports colleagues, it's very, very difficult for them to just take the player out in the field. So this was an injury to the biceps femoris muscle belly, and which was extending in the deep fibers here. And rest of the muscles of the hamstrings, like the semi-T and semi-membranosus, were intact. Also, we could see that this was a high-grade injury of the semimembranosus tendon at the pubic attachment, and there was a hematoma which was coming up in the soft tissues. And just see this sciatic nerve which is being compressed between the remnant tendon and the hematoma. So in such cases, the patient will have extremely bad radicular pain, and we need to inform all these findings as to how this is progressing. Next, after hamstrings, are the calf injuries, and calf injuries are very, very common, specifically in players who play high velocity games like tennis, badminton, and squash. And as we see that there is a myofascial injury between the two muscles. So this is a case of myofascial injury between the medial gastrocnemius and soleus muscles, and ultrasound is the best modality to look for such injuries because it's easily available, it's cheap, and one can just point out that I have pain here and we see the abnormality. So here we can see that there's a stripping injury along the myofascial junction and a hematoma coming in the intermuscular planes, and there is associated insertional injury to the medial gastrocnemius fibers at the insertion. Another DD or a differential diagnosis to such injuries is a ruptured Baker's cyst, which occasionally presents with a lot of pain and swelling in the calf region. And MSK ultrasound takes a lead over any other imaging modality in this. So we could see the large heterogeneously hypoechoic fluid collection, which was tracking over the medial gastrocnemius muscle, and it was tracking till the mid-third leg. And when we traced it proximally, we could see that this was a partially ruptured Baker's cyst with the rest of the contents which have come down.
Dr. Gaurav, sorry to interrupt. Can you sum up because
Yeah, just 5 minutes. I think I'll be done. So cruciate and meniscal injuries are another set where we can, the imaging helps us to identify what is the grade of injury, if it's a full thickness tear or a high grade injury, or it's an intermediate or a low grade injury. So various edema patterns like bone marrow edema along the anterolateral and the posterolateral tibial plateau. It really helps us to identify. There could be a flipped meniscus which has come forward here, and there is nothing left in the posterior horn, or there could be a bucket handle tear of the meniscus along with ACL injury. In cases where we have ACL injury along with posterior meniscocapsular junction ripping, this is called a ramp tear, which is very essential for us to mention before the patient goes for a surgery, or a peripheral longitudinal tear in the lateral meniscus, which is a Risberg rip. Similarly, posterior cruciate ligaments are common, which come up with avulsion fractures, but that's important for us, how important it is to delineate what kind of elevation has it got from the parent bone and what is the status of ligament. Patellar dislocations are another common areas which have been seen in sports injuries, and MRI is the best investigation to look for bone marrow contusions, patellar and trochlear morphology, the status of medial patellofemoral ligament, and osteochondral ligaments. So in cases of patellar laxity, we could see that how lax this patella looks, and this was dislocated laterally. So again, in these cases, we could see a specific pattern of bone marrow edema, and the status of the, here we could see that there was an injury to the medial patellofemoral ligament, which should be this jet black, but this looked little thick and edematous. Along with that, there could be trochlear dysplasia, as we could see that there is flattening, and this could lead to abnormal morphology and or patellar maltracking. The medial patellofemoral ligament is quite attenuated here, and in cases where there is disruption of the osteochondral fragment, it could get displaced. Specifically, in this case, it is seen in the patellofemoral recess. Again, ankle injuries are very, very common, and specifically in tennis players, in football players, and these can be high ankle or low ankle injuries. And specifically, subtle bony fractures can be picked up on MRI when it's normal on X-rays, but it's very, very important to look for if it's a Weber type B or type C fibular fracture injury or a posterior malleolar fracture. So it's important for us to rule out a syndesmotic ligament injury or an anterior inferior tibiofibular ligament injury, because it's very important to stabilize the ankle, and without surgical correction, there will be high instability. And in cases of low ankle injury, we could see that there is high grade injury to the anterior talofibular ligament, which is one of the most common ligaments to be affected in ankle sprains. This is small osteosubulgent fracture of the calcaneofibular ligament, and extensive soft tissue edema. So Achilles tendon injury is again very common, and ultrasound and MRIs can really help to identify what's the gap and how well the tissue is remodeling. So take-home points are that one should know the importance of each imaging modality. MSK ultrasound is an important tool in place which it acts as a savior at places. An X-ray should be carefully looked for. MRI, never hesitate. If the patient isn't improving, talk to your MSK radiologist in the town, and image-guided interventions play an important role in the management. Thank you very much for your attention. And I'm sorry for holding you back because it's late
Thank
night.
you, Dr. Gaurav, for going through many pathologies that we normally encounter and how MSK imaging is helpful. So to conclude this webinar, I would say that imaging plays a critical role in the diagnosis and management of sports injuries, both in upper and lower extremities. And each modality that you have described has unique advantages and limitations, and the choice of imaging depends on the specific injury and clinical scenario. So one investigation doesn't fit into all types of injuries. And by leveraging the strengths and weaknesses of these imaging, we can help guide treatment decisions and facilitate safe and faster return from sports injuries uh, in athletes. I am sure with multimodality combination of investigation and combination of imaging like what we are seeing in PET MRI, functional MRI, and advanced ultrasound imaging are likely to help significantly in future in sports injuries. And also there would be a significant role of artificial intelligence to help us guide which investigation we are going to use for what type of injuries. Thank you very much for your participation, and I thank everyone for their contribution. I now hand over to Dr. Vinita for concluding remarks.
Yeah. Thank you so much, sir. This has really been a very wonderful session today. Lot of information from you and lot of good information from Dr. Esha and Dr. Gaurav, and I'm really happy they have really stuck to their 20 minutes of the talk, and the topic itself is so wide that it will probably need maybe more sessions to actually have a complete understanding of the sports injury. So I thank Dr. Anju Aggarwal for her kind presence and giving us the opening remarks. I thank Professor Raju Vaishya for extremely important additions to what Dr. Esha and Dr. Gaurav has said. I thank Dr. Esha and Dr. Gaurav for their informative talk and really very relevant. I also thank Dr. Ashutosh Sahu for helping me organize this webinar. And last but not the least, I would like to also thank the audience for being there. Your presence has really been wonderful, and really happy to have so many of you with us today. And for your information, this webinar will also be posted on the YouTube channel of GAPIO. And I am missing to thank our technical team, especially Mr. Jitendra Malik. Without their presence and support, this webinar would not be possible. There's a minor disclaimer that in all the information given on the webinar are individual information by the faculty and not really something that is by GAPIO. So this information will also be available on YouTube channel. So thank you very much, everyone. Thank you for your presence, and really we had a good webinar today. Thank you.